So today we will do the cubital fossa. So cubital fossa is the hollow in front of the elbow joint, like the popliteal fossa, and we will explore the various parts of the cubital fossa, and we will discuss the cubital fossa under the headings of number 1, the roof, number 2 is the boundaries, number 3 is the contents, and number 4 is the applied. So if we do the dissection of the cubital fossa, we know it lies in front of the elbow joint. So we will cut the skin of the arm horizontally and horizontally on the forearm, plus we will cut in the vertical cut in the middle of the cubital fossa, and we reflect the skin. So we are removing the roof of the popliteal fossa, which is made by the skin, and when we remove the skin like this, we will find the second layer of the human body, superficial fascia, which is composed of number 1, yellow color fat, number 2, it contains loose areolar tissue which held this fat in the anatomical position. Third, it contains cutaneous nerves, artery and veins, or lymphatics or lymph nodes. So when we remove this skin of the cubital fossa, we find here everywhere where lies the yellow color fat. If you find the yellow color fat everywhere, means we are seeing the second layer of the human body, that is the superficial fascia. And in this superficial fascia, we explore the superficial artery, veins, nerves, lymphatics and lymph nodes. So what we see in this superficial fascia, that in the lower part of the lateral part of the arm there is a cutaneous nerve is this. This is called the lateral cutaneous nerve of the forearm. Lateral cutaneous nerve of the forearm, which is the terminal or the continuation of the musculocutaneous nerve. As musculocutaneous is called musculocutaneous after supplying the muscles of the arm, that is the coracobrachialis and the biceps and the medial half of the brachialis muscle. This nerve now descends and becomes superficial after piercing the deep fascia, and it is destined to supply the skin of the lateral part of the forearm. So now its name changes to lateral cutaneous nerve of the forearm. Similarly, the upper lower part of the arm is also supplied by the lower lateral cutaneous nerve of the arm. Lower lateral cutaneous nerve of the arm. And medially, what we see here, cutaneous nerve above the elbow joint. This is the medial cutaneous nerve of the arm. And in the lower part, medial cutaneous nerve of the forearm. So these 4 nerves we encounter in the dissection of the cubital fossa. Then in this, another thing which is very important to see is the 2 veins. One is the lateral vein, starting from the thumb, and it is ascending upward, traversing whole of the forearm, remains lateral, and continued laterally as well in the arm also. This lateral vein of the upper limb is called the cephalic vein. So we see the cephalic vein course going upward from forearm to arm. Similarly, on the medial aspect of the cubital fossa, we see another vein, which is also coming from the hand, from the medial end of the dorsal venous arc, is the basilic vein. And this basilic vein going medially upward. So that is the basilic vein we see. And in the cubital fossa, we see the communication between these two veins. So as the cephalic vein meet with the basilic vein, so this vein, communicative vein, is called the median cubital vein. Median cubital vein. And along these veins, we also find the lymph nodes and their communication lymphatics as well. So they accompany the veins. So here the basilic vein, it pierces the deep fascia, and now it will accompany the brachial artery, and it will continue upward as the axillary vein. So this median cubital form in the middle of the cubital fossa. So this much is the roof, that is the skin, superficial fascia, and when we remove these veins and all nerves and fat, what we see below is the deep fascia. So all these three things, they are covering the cubital fossa, so they are forming the roof of the cubital fossa. And when we remove this roof, so we are expecting that deep to this, we will see the boundaries. That is the boundaries of the cubital fossa. So regarding the boundaries, after removal of the roof, is a triangular area is visible, which form the boundaries. So this is formed by the upper boundary is formed by the lower end of the humerus, with lateral epicondyle, head-like capitulum, and medially the pulley-like trochlea for the ulnar, and the medial epicondyle continued upward as the medial border of the shaft. Above the capitulum, we find here the radial fossa, and above the trochlea, we find the ulnar fossa. And below this trochlea articulates with the upper expanded part of the ulna, that is called the coronoid process, with the shaft of the ulna, and the capitulum, as it is rounded like the capit or the head, articulates with the round concavity of the upper end of the radius, which is called the head, with the shaft of the radius, and medially there is a neck below, and the radial tuberosity, and the shaft of the radius. So the upper boundary of the cubital fossa is formed by a imaginary line, horizontal line, joining the medial epicondyle with the lateral epicondyle. This forms the base of the cubital fossa. While the medial and the lateral boundaries, they are formed by the muscles of this region, which encounter. If we see the muscles here, which we have already done, this anterior surface of the humerus bone gives the origin of a large muscle, that is called the brachialis. And this brachialis muscle will cross for its insertion the elbow joint, and it will be inserted over the anterior rough surface of the coronoid process. So this muscle is the brachialis, which is from the floor of the cubital fossa, the brachialis muscle. Then another muscle which forms the inferior medial boundary of the cubital fossa is the Pronator Tears. As this Pronator Tears muscle takes origin from the anterior surface of the medial epicondyle, just above the common flexor origin. This is the humeral head of the Pronator Tears. Then a few fibers, they also take origin from the anterior medial surface of the coronoid process. And from this humero-ulnar head of the Pronator Tears muscle crosses in front of the brachialis obliquely and laterally, and this Pronator Tears muscle comes downward and it is inserted over the lateral aspect of the middle third of the shaft of the radius. So this is the muscle Pronator Tears with the humeral head, and this is the ulnar head. So this is the Pronator Tears muscle. It's from the inferior medial boundary of this triangular cubital fossa. While inferior lateral boundary of the cubital fossa is formed by the two muscles which takes origin from the lateral intermuscular septum, which is attached to the lateral supracondylar line of the humerus. From the anterior surface of this lateral intermuscular septum, from its upper two-thirds, is the origin of a muscle which is called the brachioradialis, and from its lower one-third and adjoining part of the shaft of the humerus is taking the origin is the Extensor Carpi Radialis Longus. So this muscle is the brachioradialis, and this is the Extensor Carpi Radialis Longus muscle. So Extensor Carpi Radialis muscle is running downward and it will be inserted into the carpal bones on the radius, and above this muscle, overlapping this muscle, is the brachioradialis. Brachioradialis, so it is also going downward for its insertion into the styloid process of the radius. That's why its name is brachioradialis. From brachium or arm bone is the origin, and radialis, the name of the muscle, is telling that I will be inserted on the radius. Which part of the radius? Styloid process of the radius. That is called the brachioradialis. So this muscle forms the inferior lateral boundary. So this triangular area is present here. This triangular area is called the, what is called, cubital fossa. So this is the cubital fossa. The boundaries. Then come the floor. Floor is formed by the fibrous capsule of the elbow joint plus brachialis muscle. Then comes the contents, that what is lying in this triangular area of the cubital fossa. So regarding the contents of the cubital fossa, you have to remember a formula from medial to lateral, MBBR, not MBBS, MBBR. So medialmost content of the cubital fossa is M. M stands for median nerve. So median nerve is a medialmost structure. As we know, the median nerve is coming from the arm into the forearm. It is entering in front of the brachialis muscle, and this nerve passes downward. It supplies the Pronator Tears, plus it passes between the two heads of the Pronator Tears, and then enters into the arm, into the forearm. is the median nerve course. Then the first B, lateral to the median nerve, this B stands for brachial artery. And we know this brachial artery is the continuation of the axillary artery. Up to the lower body of the teres major, its name was third part of axillary artery. But as this artery passes below the lower body of the teres major, now its name changes to brachial artery. And this brachial artery is coming downward in front of the brachialis muscle, entering from arm into forearm, and at the level of the neck of the radius is the level. This brachial artery divided into two arteries, that is the lateral radial artery and medial is the ulnar artery. So this is the level of bifurcation at the level of neck of radius. So that is the second content of the cubital fossa. First is the median nerve, then brachial artery, and third is the again B, and fourth is the R. So third B stands for B for tendon of the biceps brachii muscle. As we know, the bicep muscle is the muscle of the arm, formed by the short head and the long head. So they both unite to form the bicep brachii muscle, and the tendon of this muscle is coming downward, lateral to the brachial artery, and because this tendon of the bicep brachii has to insert on the posterior surface of the radial tuberosity, not on the anterior surface. It is inserted on posterior surface of the radial tuberosity. But this bicep brachii can enter or can insert easily on the anterior surface. Now question arises, why it has gone on the posterior surface? The answer lies in its action. The action of the bicep brachii is the flexion at the elbow joint, but more than the flexion function, it is a powerful supinator. This is for the supination. So that's why it has gone on the posterior surface of the radial tuberosity, because when it will contract, then radial tuberosity will be raised upward and radius bone will be rotated laterally. So that is the supination. So that is the why it is gone posterior. Then as it is inserted here, from its medial border of the bicep brachii muscle, another thing happens very special. From its medial border, a aponeurotic extension of the muscle runs downward and medially across the brachial artery and the median nerve. And this aponeurotic extension of the tendon of the bicep femoris get connected to the D fascia of the forearm, that is the antebrachial fascia. It is fused with it medially. So this is a thick band of the aponeurotic extension of the bicep muscle tendon, which is inserted over the D fascia or merged with the D fascia of the forearm. And it has got a very important protective function, because this is called the bicipital aponeurosis. This extension is called bicipital aponeurosis. So below this aponeurosis lies the two main structures, the median nerve and brachial artery, and above this lies the median cubital vein. So between the median cubital vein and the brachial artery there is a separation formed by this thick aponeurotic extension that is called the bicipital aponeurosis. So this protects the deeply lying vein, because we know this vein is very much popularly used for the blood sampling plus for the IV infusion in the patients, accidentally the needle may pierce the vein through and through, and it may go down and it may pierce the brachial artery. But because of the bicipital aponeurosis, whenever the needle tries to go downward deep into the brachial artery, the thickness of this bicipital aponeurosis will prevent the needle to pierce the artery, so a venous blood sample may become an arterial blood sample, which is totally different. Similarly, while infusing the IV fluids into the patient through the veins, which has to go ultimately to the right atrium, the intravenous sample may become arterial, or a intravenous infusion may convert into the intra-arterial, which has got a very deleterious effect. This is a total effect. Patient may sometimes die because of the toxicity of the certain injections we have to inject intravenously in the cubital fossa, but accidentally they may be injected into the arterial. So this is a prevention measure. It prevents and separates the vein with the artery. So that we encounter here. Then the last content of the cubital fossa stands for R, and this R stands for radial nerve. As we know, this radial nerve is passing in front of the lateral intermuscular septum. So after coming from the radial groove, accompanied by the radial collateral artery, the radial nerve comes downward, laterally in front of this septum, passing between the brachial radialis and extensor carpi radialis in front of the lateral epicondyle. And this nerve is visible here in the lateral aspect of the cubital fossa, as it is said MBBR. So radial nerve is here, coming from the arm into cubital fossa. So this is also the content. Now ulnar nerve is not the content of the cubital fossa. Why? Because ulnar nerve lies behind the medial epicondyle. Or all these four structures, they lie in front of it. So we have included in it, as we know, like later there is a medial intermuscular septum. We divide the arm into anterior and the posterior compartment. And the ulnar nerve lies behind the medial intermuscular septum. But radial nerve lies in front of the septum, that you have to remember. And it lies behind, the ulnar nerve lies behind it, and then it passes behind the medial epicondyle. Because behind the medial epicondyle there is a definite groove is present to lodge the ulnar nerve. So ulnar nerve is not included in the contents of the cubital fossa. So this is how we do the MBBR, the contents of the cubital fossa. So last part we have to left is the applied anatomy. Regarding the applied anatomy of the cubital fossa, so many things they are helpful in the cubital fossa. Number one is the blood sampling. So cubital fossa is very important site and convenient site to collect any amount of the venous blood for the blood testing. So the laboratory people, they prefer the median cubital vein because it is safe, easily found, and it is bluish colored visible vein lies in the cubital fossa. Secondly, this vein is also used for intravenous infusions. So whenever some intravenous fluid is required to give to the patient, so this vein is very much preferred because it is easily available, plus the intravenous cannula stays for a longer time. It may be given for 1 or 2 days without any problem because it is a quite thick vein, easily found, and can be easily used for it. Third thing we use for here is the blood pressure measure. So cubital fossa is also a very important site for the measurement of the systolic and the diastolic blood pressure. As we know, whenever we measure the blood pressure, we put the cuff on the arm and we put the chest piece of the stethoscope over the cubital fossa, over the brachial artery. And brachial artery lies slightly medial to the midpoint of the cubital fossa. So the chest piece of the stethoscope should be slightly medially placed because the second content MB stand for brachial artery. So this is the why the pulsations of the brachial artery can be easily felt here. Then this is also the optimal site to measure the pulse. Usually we use the pulse for this radial artery. But if a patient comes whose both the hands they are amputated for some reason, then from where you have to take the pulse? That is the brachial artery in the cubital fossa. It can be easily measured with the help of the watch. So patient's pulse measurement can also be done by the cubital fossa. Then another thing which is related to the cubital fossa is the myositis ossificans. Myositis ossificans. What is this condition? Actually, this word myositis is a misnomer. Myositis doesn't mean the inflammation of the muscle, but something else is happening. It is related to the brachialis muscle actually. So whenever there is a sudden violent movement of the elbow joint, for example lifting some very heavy weight which is not under the capacity of a person, so because of the forceful pulling of any object, then what happens? This muscle acts very rapidly and the insertion over the coronoid process of the tendon of the brachialis is uprooted. And due to the uprooting, what happens? The periosteum is raised, or periosteum is also uprooted from the anterior rough surface of the coronoid process, and because of the uprooting, there will be bleeding. So bleeding is there and hematoma is formed at the tendon of the brachialis. And with the uprooting of the periosteum, we know what lies just below the periosteum of the bones, a layer of osteoblast cells. So these osteoblast cells will be migrated into the hematoma of the tendon of the brachialis muscle. And subsequently, these osteoblasts, they are the mother cells of the osteocytes. So ultimately what will happen? Bone formation will be there in the tendon of the hematoma of the brachialis muscle. And when the patient comes after 4 weeks or 1 month or so, what will be the complaint of the patient? That I cannot fully flex my arm, elbow joint. It is arrested somewhere here, not like this. Why? Because now the bone is hard tissue, hardest tissue of the tissue, that is the bone, is formed in the tendon of the brachialis. And patient with the flexion will be restricted. So this condition is called the myositis ossificans. So we have to surgically remove this bone from the tendon of the brachialis, then patient will get the full flexion at the elbow joint. So that is the clinical condition. Another clinical condition related to the cubital fossa is the cubital tunnel syndrome. Cubital tunnel syndrome. Like carpal tunnel syndrome, here is also something is happening that is called the cubital tunnel syndrome. And this cubital tunnel syndrome is related to the median nerve. As we know, the median nerve is coming from the arm and entering into the forearm, but it has to pierce between the two heads of the Pronator Tears. When we do the dissection of the forearm, we again see that this nerve is again passing through another muscle, which is called the flexor digitorum superficialis, which is also having a humeral head and a ulnar head. and then it has got a radial head also. So this humero-ulnar head of the flexor digitorum superficialis muscle, this median nerve, after passing and coming out of the two slits of the pronator tears, they have to pass through the two slits of the superficial flexor digitorum superficialis muscle. It means the median nerve is passing between the two muscles. First into the pronator tears, another is into flexor digitorum superficialis. So, because of the contraction of these muscles, there are chances that median nerve is pressed here. And this median nerve pressure is called the compressive neuropathy. So, patient may come with the signs and symptoms of the pain along the 3.5 finger or numbness of the 3.5 fingers, because we know this is the cutaneous nerve supply of the median nerve. Or patient may come with the weakness of the thinner muscles, because median nerve supplies the thinner muscles except the adductor pollicis, Brachii. So, like carpal tunnel syndrome, same symptoms may come through the compressive neuropathy of the median nerve in the cubital fossa, and this condition is called the cubital tunnel syndrome. Another apparent related to the cubital fossa is the VIC. VIC. What is the VIC? Is the Volkmann's ischemic contracture. Volkmann's ischemic contracture. So what is this Volkmann's ischemic contracture? We have also done in the lower limb, also in the anterior compartment syndrome. Another thing which is very common in the elbow joint is the supracondylar fracture of the lower end of the humerus. Because if you know the humerus, the lower end is very thin and flattened shaft. And usually in the children, when they fall downward on the tip of the olecranon, there is a splitting of the intercondylar fracture. It is a T-shaped fracture occurs. Supracondylar fracture occurs in the shaft. And with this fracture, what happens? Patient doesn't go to a qualified doctor. He go to some quack. And what the quacks they do? They put some cotton or something pressure in the elbow joint, quite a round thing, and they just tie tightly the elbow joint with the wooden splinters and send the patient for 1 month or 2 months. And when the patient comes after 1 and 2 months, what will happen? That during this 1 and 2 months of this condition, the brachial artery is pressed. Or when there is a supracondylar fracture is there are chances that this brachial artery may be torn, may be ruptured, because in the T-shaped fracture, the three segments, the distal segment of the humerus, lateral and medial condyle, they are separated. So this artery is liable to be trapped in these fragments of the fractured bone, and this artery may be ruptured. Rupture of the artery plus the pressure given by that quack and the tightly pressing the elbow joint, what will happen? The blood supply to the muscles of the hand, the forearm by the radial artery and the ulnar artery is stopped. And after 1 month when the patient comes, see the hand of the patient. It is claw hand deformity. Plus all the muscles of the forearm, they are ribbon-like. They are thin because of the avascular necrosis. Because of the non-blood supply to the arterial blood by the brachial artery breakage or the rupture, no blood is supplying given to the muscles of the hand as well. So all the muscles they get atrophy. This is called the avascular atrophy because of the not supplying the oxygenated blood. So when the patient comes, all the muscles become the ribbon-like, thin, fibrous, cord-like structures. And they undergo contracture also. They become short also. That's why the wrist joint is fixed in the flexion position. And this is called the Volkmann ischemic contracture. Ischemia is there. Ischemia is because of the oxygen supply to the muscle is gone because of the arterial rupture of the brachial artery. And contracture is made by the muscles of the forearm because of the avascular. So this condition is also related to the Volkmann's ischemic contracture at the, again, the cubital fossa. Another things about the cubital fossa applied, you may write about the golf elbow and tennis elbow. As you know, these two conditions, they are related to the common flexor origin and common extensor origin from the lateral and the medial epicondyles of the humerus. So whenever during the sports, these are the sports injuries. So during the tennis, so there is a sudden uprooting of the common extensor origin because of the forceful shot of the tennis. And because of this, what happens? The patient comes with the pain, complaint of the pain at the tip of the lateral epicondyle. Similarly, in the golf is again a sudden jerky movement of the stick of the golf may also uproot the common flexor origin. And patient comes with the painful condition at the tip of the medial epicondyle and movement of this golf. So this condition is called the golf elbow. So that is also related to the. Another thing about the cubital fossa is the affection of the elbow joint. So any disease, bone-related disease of the elbow joint will give rise to the complaint in the cubital fossa. It may be the infective arthritis, it may be gouty arthritis, it may be the osteoarthritis, which is the senile changes or the age-related changes in the bones of the elbow joint. So they also give rise to the pain in the cubital fossa. The 10th thing about the applied anatomy you can write down about the fracture or dislocation of the superior radio-ulnar joint. As you know, superior radio-ulnar joint is also from the floor of the cubital fossa, covered by the fibrous capsule. So any fracture of the neck of the radius or any dislocation of the head of the radius from the annular ligaments or any fracture of the olecranon tip or the coronoid process can also affect the cubital fossa. So patient may come with the swelling and the pain in the cubital fossa. So this is how you can explain the 10 points for the 10 applied anatomy related to the cubital fossa. That's all for the today.